Good afternoon, everyone. We'll go ahead and get started. Today we're talking about right-sided and posterior leads. And the thing that I will say about this, which we'll talk about again, is um, different combinations of these leads come together to form a 15 lead. And depending on your institute, on what is expected of you when you're asked to do a 15 lead. So firstly, we're going to talk about right-sided leads and posterior leads separate. And then we're going to talk about what different institutions do for 15 leads, 15 lead ECGs. And then at the very end, we will practice. But when we first created this presentation, myself, Brooklyn, and Amanda, we all came together to create this. And then we all had a different understanding of what you do during a 15 lead, which then led us down this like little rabbit hole of realizing that it's not standardized across the board. And it's really important that you know what your organization does or what's expected of you if your MRP orders a 15 lead. We'll also talk about, of course, them separately when it's appropriate to do right-sided leads, when it's appropriate to do posterior leads, and when we might need to do both. But we'll get into it. So firstly, as all of these sessions, the Ottawa Hospital, the Heart Institute, and Kingston Health Science Center came together and we collaborated to make this program. We do our best to find everything that is relevant, find everything that's evidence-based. However, things are very different per organization, as we've realized, all coming in from different organizations. So never forget to follow your organizational policies. Use this content to support your critical thinking, enhance your professional judgment, and aid you in making informed decisions. But again, it does not replace your institutional protocols. So always make sure you're collaborating with your healthcare team and referring to your organization's policies and guidelines. And this again is just my extra disclaimer that I already kind of talked about, that there's many different variations of posterior and right-sided ECGs. So just make sure you know what your organization does, and if your organization doesn't have a standard, know what, or you can talk to your ordering provider on what they expect from you when these things are being ordered. So today we're going to cover we're going to review the coronary circulation and the limitations of a 12-lead ECG. Then we're going to talk about right-sided leads. This really should say posterior leads, but 15-lead ECGs, and then modified 15 leads. And then we're going to talk about interpretation. So we're going to bring up some ECGs, look at kind of if we would wanted to consider a right-sided or posterior lead, look at posterior or right-sided leads. And then we have some practice cases and clinical scenarios at the end that we can walk through. This actual session is not very long. So the learning content itself usually takes about 40-45 minutes because there's not that much to cover. And then after that point, we have a break and then we come back and do practice. So I don't anticipate we'll be here for the full 2 hours. Usually with all the practice that's built in, it's about an hour and a half, but it just depends how much I lose my words today. But you're welcome to leave at any time. You don't have to stick around till the end. I won't be offended if you just want the content. That's absolutely fine. If you find the case studies and the practice super helpful, you can absolutely stick around for that. I definitely welcome it. But please do whatever is useful for you. As always, type your questions in the chat, or you can unmute yourself and ask questions at any time. I am not very formal at all, so please don't hesitate to interrupt me and ask questions as we go. Anything else I wanted to, oh, I accidentally have the Q&A open today for some reason, along with the chat. So when you're putting your questions in, can you please just use the chat? I would really appreciate it. Just me here today, so the chat I can keep up, but the Q&A is a bit different. So if you can use the chat for your questions, that would be super helpful for me. Okay. So the first thing we're going to talk about, as I said, is the review of our coronary circulation and the rationale as to why we might need to do some right-sided or posterior leads. So the coronary circulation, so our coronary circulation is split into right-sided and left-sided. So on the right side of our heart, we have one artery. This is the right coronary artery. We refer to this as the RCA. This provides blood flow to the right atria, the right ventricle, and sometimes the posterior and inferior left ventricle. And we're going to talk about this more as we go, and we talk about it more next week, but the anatomy of people's coronary arteries are different, which is very annoying. But it is the reality. So some people have really large right coronary arteries, and some people have really small right coronary arteries. And ultimately, blood flow gets to all the places it needs to, but depending on the person, it gets there a bit differently. So that's why we say sometimes the posterior inferior left ventricle, because it's not all the time. It depends what people have as dominant circulation, but it pretty much always goes to the right atria and the right ventricle and to the sinoatrial node. So if you remember the sinoatrial node, that's our main pacemaker of our heart. That's what should be functioning when we're in normal sinus rhythm. So important when we think about right coronary circulation, that if it's blocked, we often do get some issues with our pacemaker. Okay. So again, right-sided is the right coronary artery. That's the only artery on the right side of our heart. Mostly provides to the right atria, right ventricle, and SA node, and then sometimes wraps around to the left side. Our left coronary circulation is made up of two main vessels, but they all branch off one main artery. Hopefully this makes sense. So you can see here, this is the start of the left coronary the left coronary circulation here. This is what we call the left main. Once we get to the bifurcation, it splits into the left anterior descending. So it makes sense. This comes down the left anterior portion of the heart. It descends down the anterior portion of the heart. And then at the bifurcation, the vessel that goes in the other direction is called our circumflex. Okay. So when you hear us talk about the left circulation, you'll kind of hear us talk about the left main, the left anterior descending, or the LAD, and the circ. However, important to remember that both the LAD and the circ branch off of the left main. So if your left main is blocked, big issue, because you're fully then blocked to your circumflex and your LAD. And our left side of our coronary circulation is responsible to blood flow to the left atria, the anterior and lateral portions of our left ventricle, and then sometimes as well the inferior and posterior left ventricle. And again, I say sometimes to the inferior and posterior because sometimes, depending the person, it's provided by the RCA versus the circumflex. So it varies per person. And this is where we can, this is where we're going to separate the regions with the coronary blood supply that we expect to see. And again, some of our areas of our heart are confusing. So we have the left anterior, or our anterior, so our anterior region of our heart. So up here, when we're talking anterior, we're talking the anterior left ventricle, which sometimes trips people up because we're like, it's not the only anterior portion of the heart, but we're talking anterior left ventricle. It is provided blood by the left anterior descending artery. Okay. We have the septal portion of our heart, and I'm going to go into the leads associated with these after as well. This is also provided by the LAD, so that left anterior descending, and our septal perforators. So off of our LAD, we have something called septal perforators. And you can see them here. They're labeled like SP. And these are just little branches that come off of the LAD and provide blood to the septum of the heart specifically. The septum is that portion of the heart that separates our LV and our RV. Okay. Our inferior, again, when we say inferior, we're talking the inferior left ventricle. Most often, it's supplied by the RCA. So you can see here, about 70 to 80% is provided by the right side of the heart. So most people, when we're talking the inferior portion of our left ventricle, is provided by the right coronary circulation, using the wrong side. However, it can sometimes be that circumflex, which we talked about, which branches off the left main and wraps around the underside of the heart there. Or sometimes it's a bit of both. It just depends the dominance pattern that the patient has. Next, we have the lateral portion of the heart, which again, we're referring to the lateral left ventricle, which is over here. Usually it's the circumflex. Sometimes it's a combination of the circumflex and we have more branches just for fun off the LAD that can also provide to the lateral left ventricle. And sometimes, very annoyingly, the right coronary circulation wraps all the way around and provides blood circulation over here as well. And I mention this because as you get better at interpreting ECGs, you'll be able to tell, based on what's infarcting on the patient, of what kind of dominant circulation they have. Often when we start seeing a lot of these combined infarcts, you can tell like which vessel's blocked. And then we think about our posterior. It's again the circumflex or the RCA. Sometimes a bit of both, depends on the patient's dominance pattern. And then the right ventricle is pretty much always from the RCA, the right coronary artery. So then again, this is all the blood vessels with the regions, and then now we're thinking about our leads. So when we're thinking about leads, our anterior is going to be V2 to V5 is usually where we're looking. Septal, V1, V2. Sometimes we'll also see V3 mixed in if we have just a septal infarct. Inferior leads, we're looking at lead 2, lead 3, and ADF. And in the lateral portion of our left ventricle, we want to look at V5, V6, lead 1, and AVL. This is where the problem starts, is when we get to posterior, we are out of leads. We don't have any leads that show us the posterior of the heart. And same with the RV. We don't have a view of the right ventricle. So this is where we want to start thinking about when our cases would we suspect we might have a posterior infarct or a right ventricular infarct, and what would we do about it? And so it is important because as you can see from like the circulation, a lot of them are all interconnected. We only have 3 main coronary arteries. So often we say 3 main because we say like the RCA, the LAD, and the circumflex are kind of the 3 main arteries. But we have lots of areas of the heart. So often if one of the bigger vessels is blocked, it's going to hit multiple regions. And you can see this in like 20% of STEMIs actually hit the posterior region of the heart. And up to 40% of inferior MIs have a right ventricular infarct as well. So it is important to note that we can't see these on 12 leads, and they do have some importance to them. Especially when we're thinking about right ventricular infarct, we have a bit of different management. The other thing that's important to note is posterior MIs often occur with other MIs, but about 5 to 10% of them occur in isolation, meaning we might not see much of anything on our 12 lead, but the patient's having a posterior MI, and we might miss it if we don't dive further into looking at the posterior leads. So we'll talk more about that as we go through. So the first thing we're going to talk about is a right ventricular infarct and right-sided leads. So a right-sided ECG is exactly what it sounds like. It's looking specifically at the right side of the heart because we don't see this on a standard 12 lead. When we're doing right-sided leads, we move the precordial leads. So we move are leads V1 to V6 or some amount of those leads, which we'll talk about, but we leave all of our limb leads as is. So like we keep the right arm, right leg, left leg as is, and we move all our precordial leads. So there's 3 approaches, and this is where it's important to know what your protocol is at your facility. So the first approach is to move all your precordial leads, V1 to V6, in a mirror to the opposite side of the chest. So you can kind of see it here. You would start V1 on the left side of the chest, V2, V3, V4, V5, V6, and you would relabel them as V1 to V6R. The second method is to leave like V1 and V2 as is. So you'd have V1 over here, V2 over here, and then move V3 to V6 to the opposite side of the chest. And the fourth one is to move V4 only to the other side. And we're going to go through these a little bit more and talk about them. So this is just what these look like. So in this method, for example, we're absolutely flipping everything. You're going to have, this will give you 6 right-sided leads to look at. So all of your precordial leads will be right-sided leads in this first approach. And you put them on exactly the same way, just on the other side of the chest. This is the second option. So you leave your V1 and V2 as is, as we would on a normal 12 lead, and move V3 to V6 to a mirror image of the opposite side to become V3R to V6R. So this is a second approach that exists. And then the last approach is to only move V4. Okay, this is the one I see most commonly, and it's not bad. We're going to talk about kind of why or why not you might do this. So when you move V4, you're going to move it to the 5th intercostal space, mid-clavicular line on the right side of the chest to become V4R. This is because the most useful lead in a right-sided ECG is V4R. Okay. So ST elevation in V4R has a sensitivity or a true positive rate of 88%. So it'll detect right-sided ST elevation correctly 88% of the time. And it has a specificity of 78%. So if it's not showing ST elevation, it'll be correct 78% of the time. And it gives it an overall diagnostic accuracy of 88%. Or 83%, sorry, which is not bad when you're thinking a single lead is going to tell us 88% of the time that we see ST elevation, that it is actually ST elevation. 78% of the time we don't see anything, it's going to be a true negative. And overall, 83% diagnostic accuracy, not bad. So this is what I see done most often when we're talking getting a quick right-sided view, because it's fast, right? You pop one lead over and it's going to give you a pretty good overall diagnostic picture. Obviously, the issue is we can miss. There's a 22% chance if we get a negative that it could be positive, or that it's not a true negative, that it's a false negative. And there's a 12% chance if we have a true positive that it is not actually positive. So not a bad place to start, I will say. If clinical suspicion remains high, but V4R is negative, try doing a full set of right-sided leads and see what that finds. But overall, this is what I see the most, and it's not wrong. It has, again, quite a great diagnostic accuracy for one lead being moved, but does limit a little bit because we're missing the bigger picture and we're missing more views of the right ventricle. So when to suspect an RV infarct? Generally, speaking, a really easy thing to remember is if a patient has an inferior STEMI, You can always check them for an RV infarct. More often than not, patients with an inferior STEMI will also have an RV infarct. So in my head, that's what comes best to me. I see an inferior STEMI. I want to check for right-sided RV infarct. In patients that do have an inferior STEMI, there are some patterns that we can see on the ECG. This may or may not be helpful for you if you're very technical and that's what works for your brain. I will go through this. If you're not super technical and you just want the like, when generally should I look at right side, think about your inferior STEMIs. I see an inferior STEMI, do a quick right-sided look to see if there's RV involvement. So in patients where we see an inferior STEMI, we can often see these little signs on the 12 lead that is going to make us more suspicious of an RV infarction. So if we're thinking of our inferior leads, again, it's down lead 2, 3 AVF. Okay. So oftentimes, if we do have a right-sided involvement, you're going to see ST elevation as well in V1, which makes sense when you see like where V1 is looking at, right? It can cross over a lot with the inferior portion of the heart. This one is very specific and apparently very, very highly specific for RV infarction. If you see ST elevation in V1, but ST depression in V2, very highly specific along with your inferior STEMI for RV involvement. You can also see ST depression in V2 with a isoelectric segment in V1. Or then we look at the limb leads and you might see ST elevation greater in lead 3 than lead 2 on our inferior leads. So these are just little bits and bobs that you can watch for if you're more advanced in ECG interpretation. But ultimately, what I want you to be thinking is like inferior infarct, let's check the right ventricle. So this is a bit of a picture. It might be small on your screen. But this is a picture of like the full set of right-sided leads. So we have V1R to V6R. So we can see over here, firstly, we have an inferior STEMI. So we have elevation in lead 2, lead 3, and AVF, which we know is an inferior STEMI, which is probably what signaled this person to do the right-sided leads in the first place. So then with our right-sided leads, you can see ST elevation in V1 and V2 R, V3 R, V4 R, V5 R, V6 R. There's absolutely ST elevation in all of these leads here. So we would confirm right-sided involvement by having ST elevation in our right-sided leads. Even if we just did V4R and there is ST elevation in that lead, that would confirm that there's right-sided involvement. I think I already talked about this a little bit, but we have the ST elevation, I said, in lead 2, 3 AVF, which is probably what prompted the ST elevation, or sorry, the right-sided leads in the first place. And then we also have ST depression in lead 1 and ABL, which is our high lateral leads. And these are reciprocal changes to our inferior leads. So we often will see these reciprocal changes in an inferior infarct as well. Go ahead, Rachel.
I have a stupid question.
No, go
So
ahead.
because I never tried to put the leads on the right side,
Mhm.
does it require special ECG machine? Because I know like sometimes we put some sticker in a little bit wrong place. Some ECG machine it's like doesn't recognize. Do we
Not
require
as,
special ECG machine or just I never tried to put it in the like right side?
yeah, totally fair. Not a stupid question at all. I have a slide on it, so I'll just jump ahead to it while we're chatting about it. So it depends what your organization has. Okay, so like On older ECG machines, the likelihood is you're going to do just a standard 12 lead, or do it as if you're doing a standard 12 lead, but put your leads on the opposite side of the chest. And then as you can see here, you're going to cross out the lead and relabel them as like V4R, V5R, V6R. And it's literally that basic. Like our older ECG machines don't have that option to switch. So you just, once it's printed, you make sure you cross it out and label them properly.
Okay.
If you have newer machines, you may have the option, or you likely will have the option to go in and click like right-sided leads, and it'll tell you like how that machine works and what leads to switch over. So this is where it gets important to know your equipment because it honestly really depends on what you have available. Ours, where I worked in ICU, they're super old. So if we did right-sided or posterior leads, we literally crossed them out once it printed and labeled them. Some newer machines, and depending where you work, like some emerges have now ECG machines with 13 leads instead of 10. So you can do like your entire 12 lead plus your posterior leads all at the same time. And it'll be printed and labeled properly. But again, just depends the equipment you have.
Okay, thank you. It makes sense. Yeah.
Good. Okay. And then this question comes up sometimes, so I always like chat about this, is if we already know the patient's having an inferior STEMI, why does it matter if we know if the right ventricle is involved or not? So the short of it is management differs a little bit for right-sided involvement, okay? And if we know, or sorry, and RV infarction is really common in inferior STEMIs. Having an isolated RV infarction is super duper rare. So at least that's generally not something we have to worry about. That's why like the flag for doing our right-sided leads is an inferior infarct. But knowing if there is RV involvement can change our management a little bit. So patients with RV infarction are extremely preload dependent. And if we go back to our like hemodynamics concepts, preload is when we're thinking about the fill that comes into the ventricle at the end of diastole or the end of the relaxation period of our heart rate. It's how much blood volume is getting into the ventricles right before contraction. So blood that's available to be pushed forward in the body. So when patients have an RV infarct, they're extremely sensitive to preload. So we don't want to give them anything that can worsen their preload. So for example, like nitrates, so nitroglycerin or nitroprusside are not good things to give to patients that have an RV infarct. These are going to vasodilate the veins and the arteries and cause a lower amount of blood to get back to the ventricles and ultimately decrease cardiac output because they won't have the ability to give as much forward flow. So in RV infarcts, difference, and often, thankfully, for RV infarcts, they do present more hypotensive than hypertensive. So nitrates isn't a common thing we would go to give anyway. But in RV infarcts, we want to start with fluid. We want to be cautious with fluid, but we often want to start with fluid to treat their hypotension, to maximize the preload, to maximize the flow getting back to their heart. We even have to be cautious because like things like morphine or diuretics can reduce preload enough that it'll make these patients hypotensive. So we just want to be very cautious, and it can just help with the management in that sense. So some things we might see if the patient is having a right-sided MI, a little bit of symptoms are different, a little bit different. So in addition to our expected MI symptoms, so our chest pain, our shortness of breath, our right arm pain, our back pain, things like that, patients that have a right ventricular MI will often have arrhythmias that are more bradycardic. And this is because if you remember earlier when I talked about circulation, our right coronary artery supplies our sinoatrial node and our AV node. So if that area is infarcted, oftentimes these patients are going to have a bit of wonky pacemaker activity going on, and they're going to be bradycardic, ranging from just like sinus bradycardia to like a complete heart block. So this is often different from what we're going to see in our other areas of infarct. Again, as I said, patients are going to be hypotensive, and you might see like some acute signs, acute right heart failure signs. So patients will suddenly develop acute peripheral edema, or you might see acute jugular vein distension, like in this person here. We also will talk about the classic triad of RV, right ventricular MI, which is next. So this is kind of the signs of the classic triad we're going to see in a right ventricular MI, is patients are going to have the jugular vein distension, but their lungs are going to be clear and they're going to be hypotensive. So these are kind of the three classic signs and symptoms that we can watch for if we suspect a right ventricular MI or if we have a confirmed right ventricular MI. The other thing that is like such a weird little thing, so I worked in cath lab, as did Brooklyn, the other presenter in this series. That's where we met back in the day. And I remembered our right ventricular infarct patients being super duper nauseated. And I can't find it anywhere in the literature. So this is just anecdote. It's why I don't have it in the slides. I like legitimately could not find it anywhere. But then I asked Brooklyn, I reached out to some other people I know at the Heart Institute. I'm like, is this your experience? Or am I crazy? And anecdotally, our right ventricular MI patients in, the 4 or 5 people that I chatted with who have experience with this did say in their experience as well, these patients are quite nauseated and they are often like green, like they just look awful. So again, couldn't find anything to support me in the literature, but anecdotally from my friends at the Heart Institute, we all kind of had the same experience there. And so, as I said before, it really depends on what ECG machine you have, on what it is going to be required for you to do. So, biggest thing is make sure your ECGs are properly labeled. So, if no matter what machine you have, if you're doing right-sided leads, when it prints, if you have to cross them out with a pen and write in, the proper leads, do that. If you have a special way that you can set up the leads on your machine, you can absolutely do that. Just make sure when it prints that it's accurate, or make sure you're putting your leads in the correct spot based on what the machine is looking at. That's the other thing. We can set the machine up, but if we don't put the leads as the machine is expecting, then it's not going to be right on the printout. So make sure you know your machines. The other tricky thing with right-sided MIs is it can be hard to differentiate between a significant PE and a right ventricular MI because they can both present with a bit of right ventricular failure. So the picture might not be as clear, and both can have elevated troponin and CK levels as well. So basically, if like you and or the physician are not sure what it is, a good way to distinguish is to have your physician do a quick bedside echo to check RV dysfunction, and they'll be able to get a better understanding of if it's a PE versus an MI. Yeah. Okay. Any questions about right-sided leads before we move on to posterior leads? Cool. So again, I should have changed the title of this to posterior leads. Often when you look at post or 15 lead ECGs, it's going to tell you it's a 12 lead with 3 additional leads added to the posterior side, which again varies per organization. Amanda, Brooklyn, and our organizations all do different things. I work at peripheral hospitals. They do different things. So it really depends. And we're going to talk about that more in a bit. But when we're talking about posterior leads, we're talking about 3 additional leads that we're going to look at on the posterior left side of the chest. And again, we do this because it's not viewed by a standard 12 lead. Most importantly, depending on what machine you have, again, is we need to do, in addition to the posterior leads, a standard 12 lead. If we're talking about a 15 lead, the original 12 lead that we do are the first 12 of your 15 leads. Okay. And again, if you just have a machine with 10 electrodes, you'll move your like V4, V5, V6 to the back to become V7, V8, V9. If you are lucky to have a 13 electrode machine like some of our emerges, then you'll be able to do the full 12 lead and then add the extra 3 leads as well, which is super nice to create 15. So lead placement, it's basically the same, just posteriorly, but it's a little trickier to landmark. So your V4 becomes V7. So it's placed kind of posterior axillary line at the 5th intercostal space. Your V5 becomes your V8, placed 5th intercostal space mid-scapular line. So again, a bit different, not quite mid-clavicular, but mid-scapular. And then your V6 becomes your V9, and it's placed 5th intercostal space at the paraspinal line. So they're all placed, should be almost straight across at the 5th intercostal space, kind of spread out across the back there. It's trickier to put them on the back because backs are bonier generally. So we want to try and avoid scapula as much as we can and bony or bone in general, which again, do our best to avoid scapula, but then some patients are really ribby. Sorry for a lack of better word, but you know what I mean? Their ribs are very protruding, especially in our smaller population. And bone does not transmit electricity, so we really want to do our best to put them not over major bony prominences. We do our best. We can palpate for anatomical landmarks, of course, while we're placing them. So again, kind of posterior axillary line, then one in the middle and one at the paraspinal line. So 5th intercostal space right at the line. And then of course, skin prep appropriately. We'll often going to have to gently roll patients to put these in place. It won't be possible to put them properly when they're laying flat on their back. And generally speaking, it's easier to have them, you know, like sitting up or laying on their side while these are in place, because laying on them will often mess up your reading that you're going to get. And then why do we care about posterior MIs? And the thing with posterior is they're often missed. And they can often be missed or misdiagnosed due to more subtle ECG changes, despite that patients with posterior MIs will still present with classic MI symptoms. So as I said before, posterior MIs accompany up to 15 to 20% of STEMIs, usually occurring in the context with inferior or lateral infarctions. So if we have a posterior extension of an inferior or lateral infarct, it does imply a much larger area of myocardial damage, which gives us increased risk of left ventricular dysfunction and death. The other important thing is that unlike right ventricular infarcts, is we can have isolated posterior infarcts. So 5 to 10% of posterior infarcts are just posterior infarcts. And this is where the issue comes, is because these are often missed. And the reciprocal changes, which we're going to talk about for our posterior MIs, show up as ST depression often in our 12 lead, which then can sometimes be misdiagnosed as an NSTEMI. And ultimately, the treatment for an NSTEMI versus a STEMI is eventually the same. Like eventually, they're going to be transferred to a cardiac center. They're going to receive a cath. They might need a stent or a bypass. However, the urgency of the situation is much different. So NSTEMIs as you guys know, can be held at a peripheral hospital for 24 or 48 hours awaiting cath. Whereas if we're having a STEMI, those patients need to be transferred within, 90 minutes to get to the hardest to be at the cath lab to get their blockage dealt with. So the management is very different, and this is where the risk happens significantly with posterior MIs, is missing the STEMIs. The other different thing, we're talking about confirming a posterior STEMI on our posterior leads, is we don't need as much ST elevation. So usually we need, like 1 millimeter, one small box, but in our posterior leads, we need a half a small box of ST elevation. So it's not much. It can look really insignificant. And this makes it a lot easier to miss. And the reason we only need a half millimeter of elevation is because the electrodes are farther away from the chest wall or further away from the heart itself. So we don't need as much of an elevation to be considered a STEMI when we're talking the posterior lead. So only half one small box or 0.5 millimeters. So if we see that, we want to escalate our findings immediately. And as I said before, our missed posterior involvement results in larger areas of infarction and ultimately poor patient outcomes. So there are some reasons to be suspicious of posterior MI, but ultimately it can happen in any of our patients with lateral or inferior MIs. So it's not wrong to check in those patients. So if you have MRPs who like you to check in patients that have lateral and inferior MIs, it's not a bad idea. There is an increased mortality in those patients. One of the things you'll often see that should also make you suspicious is those reciprocal changes that I talked about. So in V1 to V3, so our septal leads, these are reciprocal to our posterior leads. So you can see here, V1, V2, V3, we have ST depression in all these leads. This should prompt you to do a posterior ECG, even if this is the only finding on your ECG, because it could be an isolated posterior infarct. We might also in V1 to 3 see tall, broad R waves, so about 7.5 small boxes. So again, our R waves are the upward strokes in our QRS complex. So you might see them be super tall and broad. Another sign is having upright T waves in these leads, which we don't always have. So these ones here, they have the depression and the upright T waves. Some of these things I don't personally find helpful, but if they're helpful for you, cool. But the biggest takeaway I want you to think about is always be suspicious in an inferior or lateral MI, and especially if you see these reciprocal changes, so that ST depression in V1, V2, V3. So again, our reciprocal changes are ST depression seen in our anatomically opposite leads from where the ST elevation is. Surprisingly, the pathogenesis of this is unknown. In the literature, it's talked about, but no one knows the reason why these reciprocal changes happen. The biggest takeaway as well, though, is that we don't always see reciprocal changes. So if your patient is presenting, with very obvious signs of an MI, like they're coming with crushing chest pain, they have a sore arm, they're nauseated, and their ECG looks fine, check a posterior. They could be having an isolated posterior infarct, and they might not have reciprocal changes because not everyone does. So just because you don't see reciprocal changes doesn't mean it's not there. And in the case, like I just talked about, like if you don't see changes on ECG, if you don't see changes on ECG and also you have a TNI that came back positive, again, that's another indicator that like we're missing something. We need to take a closer look. So not a bad time to do your posterior leads. Again, with right-sided leads, they don't occur in isolation pretty much at all, but our posterior does. And this is just a review of our reciprocal changes. So again, our septal leads, our V1, V2, are reciprocal to V7 to V9. So with ST elevation in our posterior leads, you would often see the ST depression in our V1, V2. And I think I already talked about this, but just to reiterate, we don't always see reciprocal changes. If your patient's having symptoms of an MI and the 12 lead is negative, never a bad idea to do posterior leads. If you have positive cardiac enzymes and a negative 12 lead, never a bad idea to do posterior leads. And sometimes it's up to us to advocate for expanded leads. Particularly in women, sometimes, well, not in the literature, it does show that women's chest pain is more often written off as anxiety than in men, for example. So if we are having suspicions that something is going on, please advocate for expanded leads. And other 15 lead considerations, again, really depends on what equipment you have available. So you might have to, cross your leads out and label them with V7, V8, V9 instead of V4, V5, V6. If you have a newer machine, know exactly what setup it expects you to have when you're selecting the different settings. So it might give you a setting for a 15 lead, but does that 15 lead include only posterior leads, or does it have a right-sided lead mixed in, which we'll talk about in a second? And then make sure you're placing your leads correctly based on whatever it is that you're supposed to be looking for. And make sure if, like, for example, my organization or my unit that I have experience in, for the most part, we only have 10 electrodes available, which can give us a max of 12 leads at one time. So if we need a 15 lead, we have to do the 12 lead and then move the leads to get the other 3 leads. And it's important to not have a big gap. So if, you did a 12 lead and your physician goes 10 minutes later, looks at it 10 minutes later and is like, ugh, do a 15 lead, please redo your 12 lead and then also add your extra 3 leads. Things can change a lot in 10 minutes. So we want to make sure when we are doing the 15 leads, we're doing them all in conjunction at the same time, or as close together as we can. Um, so as I said, we can often have like an inferior and posterior MI in conjunction. So this is just an example of that. So our limb leads will show us an inferior infarct. So you can see ST elevation here in lead 2 and ST elevation here in AVF. And then this prompted them to do, and then you can see here they also have major ST depression, V1, V2, V3. So all this stuff prompted them to do posterior leads. And you can see here there is significant ST elevation in all the posterior leads. And again, we often, with inferior infarcts, will see the posterior infarct or the right ventricular infarct. Okay. Any questions about posterior leads before I move on to our modified 15 lead? Okay. Um, so again, this was like tricky. So some places you look will say a 15 lead is always a combination of right-sided and posterior leads with our 12 lead. Some use just posterior leads. So we're going to talk a little bit about this. So generally when some institutions will complete what's called a modified 15 lead, where you look at the RV and the posterior wall simultaneously. So instead of doing, your right-sided and then your posterior, your V4 on your 12 lead would become V4R. So you move V4 over, and then you move V6, V7 to become V8, V9 posteriorly. So I really like this approach. Some organizations seem to exclusively do this. I do really like this approach for like a quick, let's get a view of both and see what comes up. The only issue is we're getting fewer leads reflecting each region. So like on the right side, we're missing V3, V5, and V6, and we're missing V7 posteriorly. Also really important if you're doing this to make sure we're labeling properly or setting our ECG machine up properly to capture what we're doing. I have seen one ECG machine that like this is the default 15 lead is your V4R and your V8, V9. So again, just know your equipment and know what it's set to do. Because there's no kind of standard to any of this, which is annoying. And just some difference, I just wanted to share some differences with like Kingston versus the Ottawa Hospital, and it might be different at what you guys do. And for those at TOH that are here, if this has changed, please let me know because this was from last year. But in our EDs, both in Kingston and at TOH, we have, again, those 13 electrodes instead of the 10. So at TOH, we put, our 10 usual leads on to do our 10 electrodes to do our 12 lead ECG. And then we also add the extra 3 for V7, V8, V9. And then we move V4 over to the right side. Okay, so then we would have V1, V2, V3, V4R, V5, V6, V7, V8, V9. Kingston does it a little differently. They do the full 12 lead and then then have their first additional leave. So like their 11th lead move to V4R and then add V8, V9. So these are not standardized across the board. It is very annoying. I wish I could tell you that it was standard, but it is not. So please know what you do at your organizations and in your units. It's like I worked in ICU and this is not our practice in ICU because we don't have a 13 electrode machine. So this is an example just of a modified 15 lead that you might see. So V4 you can see is now relabeled V4R. So move that to the right side. And then we have V8, V9 instead of V5 and V6. And just recapping our regions. So when we're talking about our RV, this is leads V3R to V6R. This is looking at our right coronary artery or an RCA. And we really, with our RV infarcts, want to avoid nitrates, and we usually want to give fluids for the hypotension. We're talking about posterior left ventricle infarct. We're looking at V7 to V9, and it could be the RCA or the circumflex, depending how the patient's circulation is. And these can be hard to detect. And if they're having a left or a posterior left ventricle infarct in combo with an inferior or lateral MI, outcomes are worse. It means there's more tissue that's dying and it is very severe. And then the other issue with our posterior MIs is they can occur in isolation and they can easily be missed, which again leads to poor outcomes. We're thinking of our inferior region, so lead 2, lead 3 AVF. Again, the coronary circulation varies, and with our inferior, we always want to watch for right ventricular or posterior extension. And then lastly, whenever we see a lateral MI, we want to be thinking about watching for posterior extension specifically. Okay. I'm going to pause there. Are there any questions? Perfect. If any questions come up, please put them in the chat. We're going to take a break now for about 10 minutes. We can come back at 2:05. And then we'll be just doing I'll bring up some 12 leads and you guys can look at them and tell me what you see. And then we have some case studies as well. So if you don't want to participate in that, that's absolutely okay. You're free to go. All the content today is covered. But if you want to stick around for practice, we'll start at 2:05, looking at some 12 leads and with extended leads as well. Okay, so we'll go ahead and get started with just looking at some 12 leads. As a review, we have like a ton of interpretation steps. So we have like our 8 basic for like a standard rhythm strip. And then usually when we're doing a 12 lead, we add on, or a 12 lead, we add on an extra 6 steps. The last one being look for evidence that we need right-sided or posterior leads. The one thing I will say is that the evidence for right-sided and posterior leads should be pretty obvious. So for example, if we see, ST elevation in our inferior leads, please don't do all the other steps. See that, look at the ST elevation and then go, okay, they're already having a STEMI. We may need to look at doing right-sided and or posterior leads. Okay. So the first thing I just want you guys to look at, which might be hard to see if you were previously registered, I sent a booklet today with the rhythms, which are probably easier to see in the booklet that I sent you. But the first thing I wanted to do in this is look at this 12 lead and tell me if there's a reason to do an RV ECG or a posterior leads for any reason. And you can just put it in the chat. So for this ECG, we're trying to think if there's any reason to do right-sided leads and or posterior leads.
If ST elevation in V1, we're supposed to do RV, right?
Yes, yeah, exactly. So there is ST elevation in that V1. It's important if we're thinking about like these signs that are in the context of an inferior STEMI. If they have an inferior STEMI, then these apply. If they don't have an inferior STEMI, these don't apply, if that makes sense. So Nina, yes. So you can see ST elevation in lead 2, lead 3, and AVF, which tells us this person is having an inferior MI. There's also ST elevation, good catch, Rachel, in V1, which can be a sign, again, to check for an RV infarct. However, there's also ST elevation in lead 2 and lead 3, or V3, sorry, V1, V2, V3. So this patient has ST elevation, lead 2, lead 3, AVF, and V1, V2, V3. So this is an inferoseptal infarct at minimum. And then to me, this would be enough with an inferior MI to ask my practitioner if they want, posterior and right-sided leads to see if there's other involvement. If you need help building your case, there's some, like we can kind of talk about some of these signs that we can see. So as you said, Rachel, we have ST elevation in V1, which is this reason to suspect an RV infarct. The other thing that we have is the ST elevation in lead 3 is more or greater than the ST elevation in lead 2. So that's another sign that there might be right ventricular involvement here. So I would definitely want to do a right-sided ECG or at least a V4R on this patient to see if there's further involvement. For posterior infarct, again, it's often enough to have an inferior or lateral infarct. So we do have an inferior. We could ask for posterior leads. If that's not enough and your practitioner is not that worried, there's some other things we can watch for. So we don't have the horizontal, we don't have the reciprocal changes in this because we're having a septal infarct as well. So we're not going to see those reciprocal changes. We do have upright T waves, but again, the patient's infarcting in those leads, so it's not super useful. So basically our posterior ones, like not super helpful when we're already infarcting that area. Still absolutely not wrong to check a look at the posterior, but if you're having trouble convincing your practitioner, you should be able to definitely convince them to do RV leads. The other thing I want to mention is if doing right-sided or posterior leads is going to delay the care, don't. We want to prioritize the patient transfer, STEMI treatment, etc. Okay. It can be helpful to have the information that the patient is having a right-sided MI, but we already know they're having a STEMI. If your time is better used getting them ready to transfer to OHI or getting them ready to transfer to Kingston, depending where you are, do that and transfer. When you transfer them, say high suspicion for right ventricular MI or suspicion for posterior MI. Okay, so we don't want to delay care if it's not going to be useful or not going to rapidly change things, or if it's going to delay emergent care that the patient could be getting. So in this case, the clinician did a V4R based on our previous ECG. And what do we see in V4R? So as you can see in V4R, we do have ST elevation. Okay, it's a bit hard to see on this screen. I totally get it. But we do have ST elevation. So this patient, excuse me, is having an inferoseptal MI and an RV and a right ventricular infarct. So there's a lot of stuff going on. It's likely when we're thinking about what coronary arteries would be involved in this, that there's like multiple things going on. So septal is usually from our left anterior descending or our septal perforators, whereas like our RV is always our RCA, inferior is usually the RCA, and the circumflex. So there's some weird stuff. The likelihood is the patient's not infarcting two things at once. It's that this patient has some coronary circulation that is a bit different anatomically than we expect. I do urge you, if you ever get patients back from cath lab, wherever you work, take a look at when patients come to cath lab, we will map out their coronary circulation and print it on a piece of paper and send it back in their charts. So if you're an Epic site, it can be found usually it'll be found within Epic in the like diagnostics section. If you're not an Epic site, they'll probably send a printout, but it's really cool to look at. And then you can see based on where the patient was infarcted, where they stented and stuff, kind of why certain things were infarcting. It's pretty interesting. Okay, this is the second ECG we're going to look at. So again, if you have your little workbook that I sent out, this is number 2, example 2. But I just want you to take a quick look at this ECG and tell me if you think there's a concern for right-sided or posterior leads. So first thing that, oh, I see Nina's typing. Perfect.
I think I can see ST depression and kind of a reciprocal change there.
In V1?
V1 and V3.
Yeah.
No. Yeah.
Yeah, absolutely, Rachel. Yeah. And Nina, absolutely. So yeah, you have V1, V2, V3, ST depression, which again, often sign of reciprocal changes, and we want to check our posterior leads. The other thing that should signal us to do posterior leads is not as obvious in this one, but this patient is also having an inferior MI. So there's not as much elevation as we sometimes see, but we have elevation in lead 2 and AVF. There's no elevation in lead 3. So when we're thinking inferior, we always think lead 2, lead 3, AVF. But all we need is 2 contiguous leads. So we need 2 leads within the same region of the heart to say we're having a STEMI. So lead 2 and AVF would be enough for us to say we're having an inferior MI. And then absolutely with the ST depression in V1 to V3, it'd be like, oh crap, they're probably having an inferior and posterior MI. So definitely not a bad idea to do your posterior leads. And again, because they are having an inferior, it's not wrong to check their right side as well. If that's what your practitioner wants, or it's not wrong for you to advocate for that as well. With that being said, they don't have any of the like typical markers that we see for an RV infarct if the patient's having an inferior MI. So definitely a priority in this one would be your posterior leads. So this clinician did do a 15, or did do the posterior lead, so V7, V8, V9. And you can see here, this is what they look like, if you can kind of see it. And so they do have significant ST elevation on their on the posterior sides. They're having an inferior posterior MI. And I like to go back and look at our coronary circulation. So inferior again, you're thinking usually RCA or circumflex. Same with posterior. So it'd be really hard at this point to know whether they were having a right-sided infarct or a left-sided, or like if it was coming from the right side of the coronary circulation or the left side, because it can be both, right? Circumflex or RCA could be actually helpful. Well, for that purpose, you could do a right-sided lead, but not necessary. Okay. Now I have a few case studies. Again, if you need to pop out at any time. But we have a few more rhythms to work through and some case studies. So Mary is 62, comes into the emergency department stating to sudden onset nausea, dizziness, and shortness of breath. Her breathing appears labored and she is pale and diaphoretic. Vital signs, we have a blood pressure of 90 on 60, heart rate of 78, SpO2 of 94%, respirator 24, temp is normal. What should we do for this patient?
Is that question asked like what the information we need to get more like ask the patient has chest pain or because the
Yeah,
BPM is low and
that can be
probably
something you can do. Absolutely. You can ask the patient if they have chest pain.
or assess patient LOC
Assess patient what?
like a LOC.
Yeah.
Is the patient not still alert, still like AO times 3?
Yeah, absolutely. One thing I will make sure that I talk about in this case study, for example, is women often don't have chest pain. So Women have what is considered an atypical presentation, which just means they studied men first. But we often, as women, don't get the chest pain feature when we're talking about MIs. So we
Yeah,
want to ask, pardon?
like women, if the blood pressure knows always has like nausea, dizziness, short breath, or if I need to do ECG.
Yeah, yeah, absolutely. Because we don't need the chest pain or chest pressure in order for it to be MI, especially in women. Some men won't have it either, but for some reason, it is more common that women are missing the chest pain portion, which is super weird. So for sure, in this lady, I'd want to do an ECG and some blood work and send that off. So we did do an ECG, and on a quick glance for this patient, what do we see on this ECG? And this is the third practice example in the workbook that I sent out, if it's easier to see on there.
We can see us like need to have some elevation.
Yeah, absolutely. Nina says ST elevation 2-3 AVF. Yeah. So lead 2, lead 3, and AVF all have some ST elevation. So this is immediately an inferior STEMI. What else do we see? Yeah, absolutely, Nina. So you have ST depression in V1, V2, V3, and V4 as well. So absolutely, yes. And you do have some inverted T waves like AVL, AVR, and with our ST depression here as well. Perfect. And I say on a quick glance because when there's ST elevation, I don't want you to stop and do your like 12 steps of rhythm interpretation. I want you to quickly eyeball your rhythm and see that something's wrong and act on it. Time is muscle, unfortunately, with these patients. So we want to practice just glancing at these and being able to pick out, especially when we have like major ST changes like this. Sometimes they're more subtle and you'll be interpreting a rhythm and be like, oh crap, I missed a 1 millimeter ST elevation. And like that happens, guys. But when you have major ST changes, you want to be able to quickly glance and notice. So I did the full interpretation here, but like in the case of this, you would never do this until like your patient left, right? But ultimately, this patient is having an inferior. Oh, I said inferolateral. Oh, yeah, I just missed that. So they're also having ST elevation. It's not as pronounced in V5, V6. If you take a look there, it's definitely harder to see. The V5 is like 1 millimeter. V6 is a little bit more. This is where you're like, after the fact, more thorough interpretation is helpful because now that I look, I'm like, obviously, I can see that. But sometimes when it's not more pronounced, we can definitely miss on our first glance. So this is an inferolateral STEMI. The actual interpretation is it's a normal sinus rhythm. They have ST elevation in leads 2, 3, AVF, V5, V6, and then ST depression in V1 to V4. So then my next question is there any reason in this patient to suspect RV or that the patient needs right-sided leads or posterior leads. So if we look at this ECG, do we think we need right-sided or posterior leads? Yeah, I would say both are warranted. At minimum, posterior leads, but I think both would be very reasonable in this patient. We have an inferior MI, which again is like the first thing we think about is it might be also posterior or right if it's an inferior MI. Secondly, when we're thinking of posterior leads, we have depression V1, V2, V3, V4. These are the reciprocal changes for ST elevation in our posterior leads. And the last thing is we also have lateral involvement. So if you remember from earlier, posterior involvement often goes along with our inferior and or lateral involvement. This patient has both. So I suspect there's probably also posterior involvement, especially given these reciprocal changes. So the clinician agreed and he did, first, I've never seen it done like this, but this is what I could find. So they did V7, V8. So V7 and V8 are here for some reason. What do we see in V7, V8? So we do have ST elevation and V7, V8, which confirms for us that this patient is having an inferolateral posterior STEMI. So there's a lot of stuff going on with this patient. When we have the extension into the posterior along with the inferior and or lateral, mortality risk is higher. More muscle is being injured and damaged and dying every second. So these patients are high risk. Next week is when we talk more about like STEMI management, but ultimately we need to get this patient to a cardiac center for a cath or they will die, more than likely because so much of their myocardium is involved in this infarct. So then I added this in too. So if we're thinking about this patient's having an inferolateral posterior MI, it's hard to know exactly what the culprit is because if you look, like each could be the right side or the RCA or the circumflex, for all of these, right? So it's either the right coronary artery or the circumflex. Without more information in this patient, we wouldn't know. If we did a right-sided as well as the posterior and the right-sided was negative, I'd say it's more than likely the patient has a dominant circumflex, but not that it hugely matters. I just think it's interesting. Okay, and this is our last case study. So Mr. Smith is 63 years old, admitted to hospital 10 hours ago for fluid overload and pulmonary edema from CHF, so congestive heart failure. Patient also has a history of chronic kidney disease and hypertension. Patient had a normal ECG and emerge prior to admission, but he rings his call bell and he tells you he's having some chest pain. So 4 out of 10. Started a few minutes ago, and he's having some pain in his left arm and some nausea. He looks a bit diaphoretic as well. Heart rate's 84, sats are 94, blood pressure 1 in 10 at 55. You have PRN orders for Tylenol, hydromorphone, and Zofran. What do you do? ECG, redo the ECG, give antiemetics. Absolutely. So, our priority for this patient is to redo an ECG. It was normal when he came into emerge, but he's having chest pain. We absolutely need to do an ECG. Depending where you work will depend how easy it is for you to do an ECG. Like if you have a medical directive in the unit that you work in, super lucky. Activate your medical directive and go do your 12 lead. I worked in a unit where we didn't have a medical directive, so sometimes they put in PRN orders for ECGs for us, which was super helpful. We didn't always have that. So depending what you have to do, that's your priority, is getting the ECG done. So whether you have to activate your medical directive, release a PRN order, or call your MRP, we need to get those things in a row before we think about other things. And if you need someone to come in and do the ECG, like if you're in your unit, you're not allowed to do ECGs and you need a tech to come, call them as well at the same time. You want to get them up there as fast as possible. And then absolutely, once we have like the ECG in progress, we can absolutely look at antiemetics, doing a bit more thorough of an assessment, asking him some more questions. But just with the chest pain plus left arm pain and nausea, I'm not happy with that. I definitely want an ECG. So you get your ECG, and this is what you get. So on a quick glance, what do we notice? So in this one, the changes are definitely a little bit more subtle than some of the other ECGs that we've looked at.
This one is ST depression. This 2 is elevation.
Yep. Absolutely. So 1, there's some definite ST depression. V2, we have elevation.
3, elevation.
Yep. Absolutely. AVF, we also had some elevation. So in all of our inferior leads, we have elevation. And then we also have depression in our AVL, which is another one of our lateral leads here. And we didn't talk about it today, but our 1 and AVL are reciprocal to lead 2, lead 3, and AVF. So it's not uncommon to see the ST depression in 1 and AVL when you have an inferior STEMI. These are our reciprocal changes that we expect to see. We also have a bit of ST depression in V2. You can see there. And a touch in V3 as well. Perfect. Yeah, so we're having some definite problems. Um, like I said, elevation 2, 3 ABF, depression 1, 2, or 1 ABL, V2, V3. Ooh, and inverted T waves in ABL and biphasic T waves in lead 1 and V2. Okay, inverted T waves in ABL. Let's go look. ABL, yep, there are definitely inverted T waves there. And then biphasic T waves in lead 1 and V2. Yes, I can see that. So our biphasic T waves means it starts below but finishes above the isoelectric line. So you can kind of see that there. There's like most of the T wave is there, but then a little bit above. And same with V2. Mostly down low, but a little bit above as well, which can be a sign of ischemia, which makes sense. Okay, so given this ECG, would this warrant posterior or right-sided leads or both? So as I said before, if your patient has an inferior STEMI, that can be enough to chat with your practitioner about, like, do you want right-sided or posterior leads? If that's not enough to convince them, we do have some of these weird little markers that we can look at. So in the context of an inferior STEMI, we can suspect an RV infarct if we have any of the following. So the patient in question has a couple of these. So they have an isoelectric ST segment in V1, right? There's no ST depression or elevation in V1, but in V2, they have ST depression. So this can be a sign of a right ventricular infarct and should trigger us to go investigate further. And same with, they have this extra marker of more pronounced ST elevation in lead 3 than in lead 2, which is another marker that there's likely right ventricular involvement. So again, if there's an inferior STEMI, it can be enough to do both posterior and right-sided leads. If that's not enough, these are some things you can use to like make your case as to why we should maybe take a look at them. Okay. So this this was not a great ECG, but they did decide to do a V4R. So you can kind of see R added to the top, and the patient does have some elevation in V4R. So they were able to confirm that the patient is having an inferior and right-sided MI. The other thing that's different is you can now, if you interpreted this ECG, the patient flipped themselves into a second degree type 2 rhythm. So if you look here, they're in like this nice regular rhythm, and you can actually see it's captured on the 12 lead that they flipped them. There's a pause here. They flipped themselves into a second degree block, which is again another sign that probably right ventricular involvement because our RCA provides blood to the SA node and the AV node. So keeping this in mind that we're having an RV and an inferior MI, what is the likely blood vessel that's happening or that's impacted? So given that we have an RV infarct, it's always the RCA. So this patient is likely has a coronary artery that provides to the right coronary artery that provides to the inferior of their heart as well. And then just when we're thinking about having a right-sided MI, these patients are very preload dependent, which means they need a good amount of fluid volume on board. So often if they're hypotensive, like we can see here, this guy's dropping his blood pressure. The first thing we would do for that is fluid. And we want to be cautious with our fluid because this patient is definitely at risk for heart failure, does have like a malfunctioning right ventricle at this point because it's infarcted. But fluid is generally what we're going to do to treat hypotension initially in these patients, at least. We want to make sure the tank is full enough. We don't want to give these patients nitrates, again, because they like that preload and we need it for forward flow. But often in our right infarct patients, they drop their pressure. So usually we're not giving nitrates. And then the other thing to keep an eye on is his heart rate dropped to 48 from 84. So depending, the patient might need pacing. I would say if the fluid is not successful in bringing the heart rate up, the next step might be to put this patient on transcutaneous pacing or transvenous pacing, depending what your facility has. You could potentially try atropine. It generally won't work with heart blocks because atropine works above the AV node. And generally with heart blocks, we're having issues at the AV node or just below the AV junction there. So usually it's going to allow more P waves to come through, but it won't actually increase our ventricular rate, which is what we need to do. And again, we'll talk more about STEMI management next week, but ultimately we want to get him to a cardiac center. This case study was actually based on something that happened, a true case where there was a patient, I changed it a little bit, but there was a patient awaiting transfer to one of the cardiac centers because they had an NSTEMI. So their initial ECG showed some ST depression, contacted the cardiac center. They were going to take them, but they were full right now, so they needed that 24 or 48 hours before they could transfer them over there. But the patient's chest pain was controlled. The patient wasn't having any issues anymore. And then in the middle of the night, the patient woke up, was having significant chest pain. And then instead of investigating with an ECG, he was given some Tylenol and hydromorphone and sent back to sleep. And unfortunately, the patient had a STEMI, which was then not caught till many hours later, which was very unfortunate. Probably had a lot more tissue damage because we didn't catch it when we should have. Thankfully, the patient didn't die. But it is important, with our NSTEMIs are often waiting longer and longer for care, that we're not writing off their chest pain, especially if it had went away and has now come back. We want to still be considering that it could evolve from an NSTEMI into a STEMI. Anyways, my rant is over. Thank you so much, everyone, for attending. If you have any questions, feel free to stick around. I'm happy to stick around and answer them. Hopefully this was useful and did not confuse you too much. Go ahead, Rachel.
I have a question, probably
Mhm.
not really related with today's topic. So on ECG strip, we see a QTC.
Yeah,
And could you have me why we need to read the QTC, why it's important?
the QTC.
Yeah.
Yeah, so QT interval is super important because the longer the QT interval, the greater risk for patient flipping into one of our lethal arrhythmias. So the longer the rhythm strip, the more likely the longer the QT, the patient is more likely to flip into VTAC or VFib. Okay. The QT interval, however, varies with the heart rate of the patient. So QTC is better because it's going to correct the length of the QT interval based on the heart rate.
Mhm.
Because naturally, like if we have a heart rate of 150, naturally our QT interval is going to shorten because there's just no space for it to be longer. So like that's when we definitely need to use our QT corrected because it's going to correct the QT interval based on the rate of 150.
Does the QTC has like a normal range, or I saw like some numbers
Same,
400.
you're going to use the same range as your QT interval. So it's like the 0.36 to 0.44, or sometimes you'll see it written as like 360 to 440 milliseconds. Ultimately, it means the same thing. So it's the same range as our QT interval. It's just corrected for rate.
So like the strip, I have a strip in front of me, so I do can see the QT is 438, QTC is 456. So when
Yep.
we check QTC, we need to compare with QT here, or
Nope. So that is a good example. So that's telling you if you measure your QT and not take the rate into consideration, it is normal.
Mhm.
But once they take the rate into consideration, it's elevated. So that's more accurate. And that is what I would want to report in my documentation and report to my physician to be like, QTC is above our 0.44. So we might want to watch it for extending longer.
Okay.
Does that make sense?
Yes, yes, thank
Okay.
you. I know I always like sometimes the doctor asks, what is QTC? It's like, oh, that is important. Why it's
Yeah.
important?
Yeah. So usually if you have both, like you can just document the QTC, you can kind of skip the QT. I mean, it's not wrong to document both. But when you're reporting to your physician, usually you want to give them the QTC because that's going to be the more accurate number.
Okay. Okay.
Yeah.
Thank you very much.
You're welcome.
Appreciate it.
You're welcome. And Cindy, oh, thank you so much. I'm glad it seemed easy. You're very welcome, Rachel. Okay, well, if there's no more questions, I will end the meeting here. But feel free to email me anytime. Um, and Rachel, now that I'm thinking about it, I think I forgot to send you the other recordings last week, so I will do that. I apologize. If I ever forget something, don't hesitate to email me. I totally forgot.
No
I will,
problem. Thank you.
you're welcome. I'll send those over to you today. Oh, you're very welcome, Claudette. Thanks for coming.